We'll be emailing out the recording tomorrow along with all the slides. So if you're taking notes and you miss anything, don't worry about it. We'll make sure you get what you need after the webinar is over. And now here's the agenda for today's broadcast. Michael and Randy are going to be laying the groundwork and providing context around the move from patient-centered care to patient engagement. Then we're going to explore patient engagement as a subset of patient-centered care and why it's such a profound need. Next, we'll cover what provider responses have looked like up to this point that answer that need. And lastly, we're going to address what I think everyone here has the burning desire to really know, which is how to use patient engagement to improve clinical and financial results. We're actually going to be looking at a model that has a track record and it works in the real world. So without further ado, I'm going to pass this over to Michael and have him set the stage for us. Michael?
Thank you, Sarah. I'd like to start by giving us a little bit of historical context, how we came to have this concept called patient-centeredness, a little bit about what it means both within a clinical context and a policy context. And really, patient-centeredness came to center stage with the Institute of Medicine's report in 2001, Crossing the Quality Chasm, where the IOM said that patient-centeredness was one of 6 goals, 6 pillars of the U.S. healthcare system in the 21st century. And really, this was the first time that a medical organization had put patient-centered care up there with traditional clinical measures, such as safe care, effective care, or other kinds of policy measures like equity or efficiency or timeliness, and really brought patient-centeredness to the center. And just by brief way of background, what you had in the 1960s and 1970s was the growth of a patient empowerment movement, that was the phrase used, out of the civil rights movement and out of the feminist movement. And then you end up in the late 1980s with a group called the Picker Commonwealth Program on Patient-Centered Care, some academics in Boston who invented the term patient-centered care to kind of put all of this together and tell us how we could see healthcare through the patient's eyes. That was the title of a book they wrote. And I think if you just kind of remember that phrase, through the patient's eyes, that will serve as a guide as we go forward, as we look at the different definitions, the different concepts, the different ways of taking an ideal that's easy to agree about, but then turning it something that's ideal into something that's real. Next slide, please. So this definition is from the Institute of Medicine, respectful of and responsive to individual patient preferences, needs, and values. Patient values guide all clinical decisions. And you may have heard a soundbite version of this that goes, nothing about me without me. And that's great, and it's a wonderful little soundbite. But when you try to drill down and say, well, patient preferences, needs, and values, it turns out that this is a pretty all-encompassing definition that literally has been used to include everything from a clean hospital room where you have the housekeeper's name next to the bedside so that if you have a problem with the room you can call directly, which is certainly patient-centered, to genomic medicine, which is certainly personalized, to shared decision-making. So all that's great, but it covers an awful wide spectrum of things to do. And what we're going to try to do in this webinar is to condense that to something that's implementable, to something that's actionable, to something that really is what you could do in the front lines of care now and meet some of the demands on you. Next slide. So what is patient-centered care and what isn't? And this is a slide that was put together by myself and my colleagues, Joel Weissman and Sterling Herring at Brigham and Women's Hospital. We're doing a grant under the Robert Wood Johnson Foundation on best practices by ACOs in patient-centered care. And the problem is that the term is enough for everybody to think that they're doing patient-centered care, and what exactly is provider-centered care? Well, you can see a number of examples here, extended appointment hours, opening the notes to share with the patient, shared power, teams. What's interesting about these definitions of what's provider-centered and what patient-centered care is is that a lot of these have come out of the grassroots from different stakeholders, the patient community, clinicians, professional societies, hospitals, health plans, others. And what it tells you is that this concept, which was kind of a 30,000-foot concept, is now becoming mainstream, socialized, part of the values of all the different stakeholders in healthcare. It's moving from something that was nice to something that's necessary. It's moving from something that is kind of academic to something that's operational. And that's important. That means that it's becoming part of what practicing medicine, part of what having a healthcare organization is all about. It's not a fad. It is, in fact, becoming a pillar of healthcare, lo these many years later. Next slide, please. So this definition here is interesting. It comes from Health Affairs, from some researchers in the American Institutes of Research who've also done a lot of work with different stakeholders. An Institute of Medicine roundtable in 2013 came up with this kind of definition as well. And what's fascinating about this is how different it is from 2001. And the difference that is most salient, of course, is in 2001, in a fee-for-service environment, patient-centered care was kind of an ethical ideal. If you look at this definition, what it's telling you is that we need to see patient engagement as an integral part of what we need to do to build a value-based healthcare system that delivers lower costs, higher quality, and better health. So patient engagement now moves from one aspect of patient-centered care, from something that is good to do or something you kind of do to get medication compliance, to a central policy aspect of what American healthcare is all about. And we'll talk a little bit more about that in a few moments. Next slide, please. Well, at the other end, you have this definition from the Center for the Advancement of Health, which kind of leaves out the healthcare system entirely, right? Actions people take to support their health and benefit from their health care. But again, this is important because this is coming from stakeholders who are trying to define this, and they're going to define through these definitions, are going to end up defining how you get paid, what measurements of care are done, what the public expects from you, what individual patients expect from you, all of these kinds of cultural norms that define what we do and what we don't are all coming to play now in patient engagement in a way that just simply wasn't true 10 years ago or 15 years ago. Next. And then you have this very simple one. The aim of patient engagement is to transform the care relationship. And as we're through the patient's eyes, there's really an advantage to thinking of this in simple ways and then going down to the actual concrete steps you really need to take to make it work. And I think, you know, one of the things that excites me about being on this webinar is the kinds of concrete steps Pharos has taken to make this implementable, as well as something in thick white papers put out by the Institute of Medicine or something in academic journals. And with that, I'm going to turn it over now to Randy Williams.
Well, thanks, Michael, and I agree with you that a lot of the definitions that you've shared with us have been maybe less practical than those of us who care for patients are able to actually use every day as we think about structuring our practices and implementing our care models. Well, I wanted to share a little bit about my personal journey in this area of patient engagement as well with our audience today. And as Sarah mentioned, as a practitioner caring for people with chronic diseases like heart failure, it became very, very clear to me that one of the critical missing pieces of the puzzle was actually getting patients involved in their own self-care. Without getting them as a part of the team, which was all the aspiration of the Institute of Medicine's definition, we weren't simply going to be able to help them stay healthy enough to stay out of the hospital. So as Michael's nicely shared with us, the Institute of Medicine and the Triple Aim really gave us a moral imperative to shape our healthcare system around patients and their own personal ownership and involvement in their care. And the Affordable Care Act gave us a business mandate to do that work. But those of you who are listening are probably also really familiar with all the conferences and articles that are out there helping us think about what to actually do differently on a daily basis as we care for patients. Well, I've attended a lot of those conferences myself, and I'd have to say that at each of them, one of the things I do is make a point of asking the speakers if they would give us their definition of patient engagement. And frankly, most of the answers that I get are, even though a fundamental question that is being asked, the answers are really unsatisfactory. And most of the time it's because they can't tell me how I would actually know an engaged patient if I saw one, or how I would be able to differentiate an engaged patient from one that wasn't engaged. So for me, one of the most important things was that we needed to find something that was defining patient engagement in a way that was practical and measurable. So we decided that we needed to create a definition that would help us focus our care design work and intervention work at Pharos on knowing if what we did was actually working and whether it was actually helping patients get engaged and stay engaged. So we came up with a phrase that you'll see here on this slide that says that an engaged patient is one that is regularly, consistently, and persistently involved in their own self-care. And after all, engagement for us is about getting patients to be active participants in their care, and our argument is that patient engagement is actually a verb. It's best recognized by the actions that patients are taking. And as we'll share in a bit later in our presentation, those actions, especially for people who have chronic conditions, need to be both regular, oftentimes even every day. They need to be consistent over time, and they need to be ongoing for the long haul in order to improve those patient outcomes that we're all trying to help support. So Michael, I'll hand it back to you, and we'll hear from you next.
Great, thank you. I really would like to second what Randy said about the confusion over the definition. As I mentioned, I'm working with a couple of colleagues at the Brigham and Women's Hospital to look at patient-centeredness, best practices by ACOs, and we find definitions all over the place. And I think patient engagement as a verb is very helpful. What I'd like to do for the next few minutes is go over some of the regulations on patient-centeredness in ACOs from CMS. And I want to do that because it sets the stage in a couple of ways. The first is we're talking here about from ideal to real. How do you implement? This is the most comprehensive, detailed set of implementation guidelines ever, anywhere on this topic. In fact, they're so comprehensive that CMS has not really gotten around to enforcing all of them yet, but of course you can't count on that forever. The other reason these guidelines are important is when the federal government sets a standard, even if it's only for a limited group of providers, in this case for Medicare ACOs, it's a standard that is soon copied by the private sector, and as we know, there are quite a few private sector ACOs, and will frankly spread eventually to all bundled payment kinds of initiatives. So as many of you know, we got rid of the old Medicare payment system with the SGR for physicians, and in the next couple of years we're going to have a new Medicare payment system that's going to throw a lot of programs together and change the entire payment system. And that new payment system includes the kinds of measures to some extent that you'll see here. So this is really how you're going to be measured publicly, how you're going to be paid, how you're going to be evaluated, how medicine is going to be practiced in the future, laid out in advance by the ACO program today. It's a leading edge kind of indicator, and that's why we're going to spend a few minutes looking at it. Deep within the Federal Register, I talk about this some more in a white paper I did a couple of years ago, Building Patient-Centeredness in the Real World, which is on my website, but this is an important kind of context for you to understand the pressures that you're going to face. And the very first is governance, right? The people in politics like to say that people are policy. Who you put into office determines what kind of actions happen. And here you have a Medicare beneficiary without a conflict of interest on the governing board of the ACO. meaning not a retired doctor or someone such as that. The experts we talk to say one beneficiary is great, but you really need 2 or 3 so that they have some peer support. That's not a governmental requirement today. You can imagine your governance changing tomorrow. Next slide, please. This next requirement goes down to the individual doctor-patient interaction level. And it talks about promoting patient engagement, clinical knowledge, how it's communicated, and shared decision-making. Very granular. There's an entire section of the Affordable Care Act on shared decision-making, so we're going to see a lot more emphasis on that. It's saying that you need not only the governance at the top, but you need to have specific interactions with the doctor and the patient whose nature you change so that they're more patient engagement oriented. Next slide, please. Coordination of care. Of course, we've all heard about what's required with a patient-centered medical home. Note how this is across the whole continuum of care, right? Acute, post-acute, providers, and suppliers, right? So now all of a sudden we include handoffs. We include handoffs inpatient, outpatient, post-acute. A lot more complicated to implement than I want my diabetic to take her medications. Next slide, please. Access. Written standards in place and a process in place for beneficiaries to access their medical record. So yes, we all know that for many, many years, all patients have had a right to their medical record. You start to get to people having an easier time accessing it, an easier time taking their own information and perhaps showing it to another clinician, using it online, all sorts of other things. We start to change the interaction, the basic rules of the game, to one where engagement becomes the environment in which we all have to operate. There's a lot of sort of cultural shifting going on here beneath the bureaucratic language. Next slide, please. Individual care plans. The one that strikes me here is evaluate health needs using criteria such as race, gender, sexual orientation, disability, and income status. Well, I don't know about you, but where I get my care, I'm not sure that my doctor really knows much about my income status. I suppose we'll know about some of the other things, but you know, when it comes to race, sometimes doctors guess wrong for people of different ethnicities than themselves. And what this tells you is that patient engagement is an intimate activity. It's one where we really have to understand the variables. It's one where, if you look at the literature, and I'm not going to go into that in any detail today, it makes a difference. Is the doctor a woman and the patient is a man? Is the doctor black and the patient white, or vice versa? What about income? What about the language you use? And all of this is good, to be honest, because as everybody here remembers from the quality and safety movements, it's great to be in favor of high quality care, it's great to be in favor of safe care, but you can't really do it until you get past the cliches and get down into the nitty-gritty and really look at the details of what does it mean to be safe in this particular process of care for this particular kind of patient or quality care. And that's what we're doing here. That's what we're starting to do in patient engagement, is we're getting down into the nitty-gritty, into the real details of how do we relate to individuals. Next slide. The regs also talk about evidence-based care and quality improvement and internal reports on all these kinds of measures. So as I've said, so far, CMS has not really monitor this in any great detail. I would not count on CMS not monitoring you to happen forever. I don't think that's necessarily a really good bet I would place. Next slide, please. And finally, community health, and that's a fascinating kind of requirement. What does that mean to engage the community, to engage stakeholders? Not sure what that means. But I do know when you take all the slides we've just spoken about regulations together, you were being asked to implement a whole bunch of ideas, concepts, whatever you want to call them, at once that have never been implemented at once in so many ways with so many different people. And that's kind of why guidance and trying to make this something that is implementable is becoming critical in the years ahead as all of this comes to a head. Next. So what we have to measure this for the moment is the CAP scores. As you know, there are 33 different domains of quality that are being measured for ACOs in Medicare by CMS, 7 of which, the first 7, have to do with the patient-caregiver experience. All great, not anywhere close to measuring all the different things they're asking you to do. Just a first step. And so if you look at your CAP scores and they're really, really high, we've looked at this in our academic project. Everybody has high CAP scores. Some people have incredibly high CAP scores. Some people have very high CAP scores, but there's really not much difference. So if you're going to prepare for the environment, we have to really do all these different kinds of engagement activities with individuals in a very sensitive way, because that's what we're asking for, to gender, to race, to clinical condition, to the medical evidence. You need something more than your CAP scores. And as you can see here, this is from an article just in the last few weeks from BMJ Quality and Safety that says we really don't have a lot of tools that are valid and reliable measures of patient participation in healthcare. So we're flying a bit blind here at the moment. Next slide, please. So there are a few folks who are out there trying to use the tools that we do have, one of which is the patient activation measure from Judy Hibbard in Oregon. And if you look at the left, this is telling, of course, how many individuals have one or more chronic conditions and why patient engagement is so important. And what's interesting on the right is a study that was in the Journal of General Internal Medicine, 12 of 13 outcomes at the Fairview Health System in the Twin Cities were linked to improvement when you use the patient activation measures, prevention, unhealthy behaviors, clinical indicators, utilization. Not causality, but starting to move in that direction. And so we're seeing that something that sounds academic, patient activation measure, can provide real clinical usefulness when it's implemented in a sensitive way and used with a true goal in mind that has to do with certain clinical kinds of endpoints being met. Next slide, please. And this is lastly, for my part, a summary here where you see that there is a lot of evidence for this. You know, one of the things, again and again, every time you talk about patient engagement and patient-centered care, people kind of have this fuzzy, CAPS means patient satisfaction, means is, you know, are the rooms clean and the nurse answers the bell quickly and everybody's happy because the room is decorated nicely. And that's great and it's good, but it's not what it means. And so before I turn this over to Randy, I want to stress that if you look at the medical literature, there is a great deal of evidence showing that there is a link between some of these kinds of scores when we can measure, and we can't measure everything we want to measure yet, and real clinical endpoints, real outcomes, real economic outcomes as well. And on that note, I love what Randy said at the beginning about how he got into this and how he really wanted to make sure that it was measurable and something that you could do, and I'm going to turn it back over to him.
Well, thanks, Michael. I'll try to share with our audience a bit now about some of the real world of doing patient engagement, and from over 15 years of our experience of directly helping support ACOs as they make that journey clear back to the days before they were even called ACOs in many respects. But in the real world of care, those of us that take care of patients all know that we need to get our patients more directly engaged in their own care. And that's typically something that is particularly relevant for people who have one or more chronic conditions. And of course, these days, you know, the vast majority of patients that come through our various facilities and interact with our care deliverers out there have one or more chronic conditions. So engagement is particularly relevant to them, and we'd like to talk a little bit more about how that might work and be best structured. Well, engagement in their self-care is critical for improving the cost of care, the quality of care, and indeed the patient experience of care as well. The difficult part is that this level of engagement is mostly about changing behaviors, and behaviors are not easy to change, right? I mean, this is the stuff that, you know, for better or for worse, many of the things that some of the other tools or measures that Michael's presented shine a light on the problem, but actually don't give us much guidance in terms of how to actually improve or change that level of patient behavior or engagement. Well, behaviors that need to occur every day over a long period of time are the kinds of behaviors that are sometimes the most difficult to change, but they're also the ones that tend to be the most relevant for people who have chronic diseases. And as it turns out, in order to change behaviors, we and others have learned that the new behavior has to become part of a daily routine, something that we like to call rote behavior. They need to become something that we just do, to steal a phrase from Nike. But if patient engagement is actually about driving a new set of healthy behaviors and making those behaviors stick, then what we need to think about a bit more is a conceptual framework for actually making change happen, or behavior change happen. So in our next slide, I'd like to talk a little bit about an analogy that we use a lot to help explain how behavior change actually works for patients. To really understand this piece of the patient engagement puzzle, we've borrowed pretty heavily from the work of Dr. B.J. Fogg from the Stanford Persuasive Technology Lab, and I'd like to share a little bit more about his model of behavior change. Well, let me try to summarize the model rather than going into deep detail for you on the call by using an analogy, and in this case I'll use the analogy of camping. So imagine that you've gone on an all-day camping trip, and it's been raining and it's been chilly as the sun sets, and now as the sun goes down, the rain has finally stopped, and you're ready to set up camp and get your campfire going and prepare dinner. Well, the firewood you found and gathered is wet, and you didn't bring a lighter along, and you are having a really tough time rubbing two sticks together to get the fire started. Well, that's going to take a long time, and you'll likely give up before the fire is started, unless, of course, you're really motivated to get that fire going and you're starting to get really cold. Well, behavior change is pretty similar to this camping analogy. If a change is needed, the amount of effort to make that change is going to be a function of really three variables, and I'd like to describe those for us. The first is the variable of how hard or how easy the change actually is. And in this case, think about the firewood in our analogy, and if it's wet firewood, it's going to be pretty tough to get that fire going as opposed to nice, dry kindling. The second variable is actually how motivated or not the particular individual is who's being asked to make the change in their behavior. And in this case, again, going back to the camping analogy, think about, I'm getting really cold and I don't have my mittens with me, so I'm pretty motivated to get that fire started. And then the last critical variable is actually the stimulus or the triggering event that drives that change to occur. And in this case, again, going back to our camping analogy, the harder the change is, or the less motivated I am to make that change, the more powerful that stimulus trigger actually needs to be to get the change to happen. So if you think about the fire analogy, the stimulus of rubbing two sticks together is a pretty tough, challenging trigger, whereas pouring lighter fluid on the wood and throwing a match on it is a lot lower or easier of a stimulus or trigger. Well, you can all think about how this analogy applies to patient behaviors, but what we've learned at Pharos over many years of actually watching patients change their behavior is the power of making it simple and keeping patients focused on the things that they're able to do today to take small steps toward their goals. In other words, the importance of keeping or helping patients engage in regular, consistent, and persistent self-care. So now let me share a few examples of what I mean. In the next slide, I'll talk about regular engagement. Well, it turns out that there's been a lot of research done on this issue of regularity in self-care, and actually a clinical trial that was recently published out of Duke University and the University of North Carolina looked at the fact that actually taking behaviors and making them daily seems to be the most powerful way to drive behavior change. And the researchers took a group of overweight individuals over a period of 6 months, and they were interested to see whether there was a difference in the amount of weight loss or the execution of weight loss strategies when they looked at participants who actually tracked and reported their key self-care behaviors every day versus participants who were trying to lose weight but didn't track and report their self-care and their weight each day. Well, it turns out the results are pretty striking. It turns out that patients who participated in weighing themselves every day and reporting on those key behaviors and strategies of losing weight actually lost more weight than individuals who weighed themselves regularly but didn't do it every day. So it turns out that doing something every day seems to be a critical factor in driving regular patient engagement. Well, you can think about that in your own patient care analogies as well, but one of the critical things that we've shared with you is that any good measure of patient engagement needs to be measurable. And so in terms of measuring regular engagement, I think it's actually pretty simple. There are some examples here on the slide that will illustrate this to make the point, but I think you can all imagine that it's pretty easy to measure a number of days, for example, that a self-care action has taken place over a given week or a given month for issues like how many pills have been taken every day, or how many blood sugars have been checked every day, or how many calories were counted or walks taken each day. Well, in the next slide, the other critical part of behavior change is consistency, and consistency of patient engagement is something that builds on the importance of regular patient engagement. Regular patient engagement is important, but it's not enough. Consistency happens to be the next element in getting patients to be more involved in changing their behaviors around their self-care over time. So getting them to do something consistently over time is pretty critical. The best behavior change approaches drive new behaviors, and they make those behaviors rote. In other words, people don't have to get up and think about it, they just do it consistently over time. And conversely, an illustration would be that it's not like following a fad diet that ends when the holidays begin. Well, again, just like regular engagement, we want consistent engagement to be measurable. And here are some examples of how consistent engagement in self-care can be measured and how consistency is different from regularity. Were medications to be taken once a day over a month, but then happen to be only taken sporadically in month 2, 3, and 4, well, that wouldn't be a consistently engaged self-care pattern. Were blood sugars tracked for a week, but then forgotten to be monitored for the next 3 days? Again, inconsistency in that self-care reporting and monitoring. Were calories counted during the week, but then on weekends, for whatever reason, that wasn't happening? Again, a lack of consistency that keeps this from being a rote daily behavior. And then lastly, in the next slide, the dimension of persistent engagement. We need to look at whether or not patients are persistently engaged in their self-care. Persistently engaged patients are individuals who are also so engaged in their own care that they don't want to stop even after the positive actions have started to manifest and show benefit. So these are the folks who stick to their diet long term. These are the folks who are diabetic and recognize that that's a condition that they're going to have for life, and so they need to monitor those blood sugars even when they're under control. And those are the patients whose medication adherence for the long term is as long as the physician prescribes them. So at this point, I think it would be helpful for us to really drill down on how it is that we deliver this type of an engagement model assisting our clients and ACO organizations across the country. So with your permission, I'll go ahead and move to the next slide to talk about our model for actually helping patients become engaged in daily, consistent, and persistent self-care. At Pharos, we've been assisting these organizations who've been about this work, and mostly they're trying to manage large populations, and they're engaged in reducing the risk of avoidable admissions and readmissions. And while most of our clients have thought about patient engagement as something that they do every time they interact with their patients, we've helped them to understand the importance and the power of actually driving that interaction to one that's regular, consistent, and persistent, and changing behavior of their populations, especially with chronic diseases, as a result. And in order to accomplish that, we've had to leverage the important opportunities of patient engagement technology. Well, using the Pharos model and leveraging daily self-monitoring technology called teleassurance, our clients have actually been able to get greater than 90% daily patient participation rates in their self-care. Well, here's how it works. In step one, we work with our customers to make sure that they're properly identifying those people who need to be engaged in better self-care patterns. So, for example, people who are transitioning out of the hospital or who have a chronic condition. In step two, it's important to engage those patients and get them started. And a lot of times that involves a critical endorsement of this new behavior change by their provider, their physician, or someone that they trust in their self-care. And that trusted relationship can be leveraged to help those patients get started. Think of that as throwing gasoline on the fire and making that change easier for them to contemplate and take on. Well, as we help the patient get started, the next most critical step then is monitoring each day whether they're reporting on their daily self-care and their clinical status. And again, they're doing that self-care reporting through a technology platform that they can access very easily wherever they are each day, no matter what their preferences might be. So for example, if it's easiest for them to pick up the phone, they can use a telephone. If it's easiest for them to use a smartphone app, well, then that's just fine as well. And then if it is easier for them to do it through an connected device, then that's also available. It doesn't matter, and on any given day, the expectation is that they use whatever they prefer and find most easy to consistently use. Well, as they do that each day, we're also monitoring to make sure that new behaviors are occurring by monitoring each day whether or not the patient is reporting in, and using some algorithms to help identify people who are at risk of falling off that consistent pattern. And by using these algorithms, we're able to not only flag individuals who need some specific follow-up and attention to make sure that they stay engaged for the long term, but we can also then help troubleshoot issues and challenges for that behavior change. And then lastly, the same algorithms are also available to our clients to make sure that they can track and identify individuals who are getting clinically worse or might have an issue or a challenge in their self-care that our customers are able to help support and improve. And that whole system of care, although it sounds fairly complex, is actually something that we've been able to very consistently implement and produce dramatic improvements in not only patient satisfaction, but also the efficiencies and effectiveness of our clients' staff by increasing their caseloads. And then lastly, a substantial and consistent reduction in readmissions at 30 days and all-cause hospital admissions over the long term. So let me hand it off now to Sarah and let her help starting to wrap us up.
Sure. Actually, we're going to share this next slide with Michael. Michael, can you just talk to us a little bit more about where we're at with, patient-centered care right now? I mean, we seem to be just at the beginning of this, and yet, the discussions have been going on for quite some time. So, love to have you just take us through this a little bit more, and then we'll close it up and start taking questions.
I'd be happy to. And I think the one point I'd like to emphasize is that that whole from nice to necessary that I started with is now gaining speed. That because patient engagement is essentially seen by all stakeholders, and just to interject a little political note, it's neither liberal nor conservative. It's not going to change under a Republican administration or a Democratic administration, because everyone sees this as the path that we have to follow, with chronic disease gobbling up more and more of the Medicare budget and more of the budget of private health insurance companies. We're going to see a lot more attention on how do we do it, not just, gosh, we need to do it. And that's why the kind of points that you see up here are going to be more salient. We're going to look at the ROI of different ways of doing it. We're going to look at what works in pilots and what works when it's scalable. And as you know, the whole experience with disease management showed us that something that seems like a panacea at first may not quite be as effective as everybody thought when you look in more detail. We're going to try to have training of providers on this, as Cleveland Clinic has done, for instance. We're going to have shared decision making, which is difficult to implement, become more mainstream. We're going to have more tools, and we're going to reach out to the community. All of the kinds of implementation and measurement issues that Randy just discussed are going to become part of the everyday practice of medicine, part of what health insurers do, part of what all payers look for when they have the reimbursement, including in the new Medicare reimbursement rules. And so as we think about this, if you're an ACO, you need to think about what Medicare requires of you today, what you're going to need to do to prosper tomorrow, and really how to fit implementation of this into the framework, into the workflow of everything else you're doing. It's a doable challenge. It is a challenge, but ultimately it's going to make the practice of medicine more enjoyable, more fulfilling, better relationships with patients, and I think really an exciting and positive time for all of us as we go forward. So Sarah, I'll let you wrap it up.
Sure. Thank you, Michael. So just to share one more slide here, Randy, I know there's a quote that kind of encapsulates what we talk about a lot in terms of behavioral change for patients and patient engagement, and so I'll let you speak to that.
Yeah, thanks. And Michael, thank you also for sharing your thoughts and your insights and experience with our audience today. I'll just wrap up my comments by pointing to this quote from former Senate Majority Leader Bill Frist. And Dr. Frist, as many of you know, is not only an accomplished politician, but is a physician by background and experience as well. So I can really relate a little bit to where his heart is coming from in this quote. And that is that only 10 to 15% of an individual's health status is attributable to the healthcare services that they receive, and that an individual's behavior is by far the most single important contributor to his or her overall health. Well, because today's care models are beginning to put patients at the center, and through technology and process changes, we're able to reach and interact with patients in new and compelling ways. I'm very encouraged that the promise of the triple aim is actually coming to fruition now. And I want to thank those of you who've listened today to our comments and who are helping drive this transformation of our healthcare delivery system and putting our patients and their self-care needs at the center. So thank you for allowing us to share with you today what we hope are some helpful insights, and we're looking forward to your questions during the Q&A period.
And that's a great segue. We've got about 10 minutes left until the top of the hour, and so please feel free at this point to share your questions, and if you want to direct those to a specific individual, that would help if you just put that in the chat pane for me. So you should be able to find that up, usually in the right-hand corner of your screen. So feel free to send in any questions that you have, and we'll have Michael or Randy address those. so far. Any questions, anyone? You're a quiet group today. If there are not any questions, we can certainly wrap this up now. I did want to give you all the, certainly there's an opportunity. If you think of something later, you can drop me a note, and I will certainly convey that to Randy or Michael. In the meantime, I'm going to just take us to our closing slide here. I'll be sending out the link tomorrow for this archived webinar along with the slides. So if you missed anything or want to review anything, that'll be coming to your inbox. Quite a bit of what Dr. Williams talked about today is in the ebook that he wrote, and Michael so kindly wrote an endorsement for. I've got a link up on the screen for that, and again, I will send that through in an email tomorrow as well. But the ebook really takes a little bit of a deeper dive into Dr. Fogg's work on the behavioral model, which I think will be of interest to those who found the camping analogy compelling. And there's a little more information in there about consumer engagement and what we can learn from other industries who, engage their clientele, and how in healthcare we're really doing the same thing essentially. And certainly for more of Michael's excellent work, I'd love to direct you to visit his website at millenson.com. You can follow his blog. He's on Twitter, covered in the media, many good white papers and other research. So you will not be disappointed to check out his site. And I just want to thank everyone for joining us today. So last but not least, we will be producing another webinar in the next month or so. Just want to give a quick plug for that. We'll be talking to Community Health Network, one of the MSSP ACOs that achieved shared savings this most recent performance year. And so I'm sure you'll want to hear how they did that, and we look forward to sharing their story with you. So thanks everyone for joining us today.